Margaret Cahirlock, good morning. I suppose to follow on a few of the questions there, my colleague Deputy Ellis mentioned that mental health issues are 4 times that of the general population. But there's also an estimate that 1 in 3 have an intellectual disability within prison. And I know the data is incomplete, and you reference data, and that better data collection is required. But I mean, even you say that information on the mental health conditions in prison was completed in 2003, 2005. That's 20 years ago. Why is that not done on an ongoing basis to, to assess the prison population? Because I know prisoners come and go, but I'd say there's probably kind of a pattern overall of the numbers of people. And just on information around the prison as well, is it provided in accessible format as well? I mean, and do prisoners have access to reasonable accommodation? Perhaps if they have been using an iPad or have dyslexia or have, a reading difficulty or an intellectual disability, is it provided for them? You also say that at any time 2,000 people are either working with or waiting for psychology. The waiting for psychology is a bit of alarming if there's that many waiting. So I'm just wondering, are psychologists employed and health and social care staff employed in every prison on a full-time basis, or do you actually just bring them in from private sector if and when needed? And I suppose many people with mental health difficulties, they commit a crime, but often if they had received proper support in the community, they wouldn't have committed the crime in the first place. Or they end up in the prison system because they are refused entry to a psychiatric unit. Okay, I recently had contact from a family who have a member in that very situation, and they're extremely worried about him. He's refused contact with them, so I don't know if there's anything that can be done there. He's an adult, obviously he's refused contact, so they have very little information, which is adding to their distress. They're also informed, but they don't know if it's a reliable piece of information, that he's handcuffed most of the time. Now, maybe you would comment on restraint where somebody is fine. I'm presuming that's not the case, that somebody couldn't be handcuffed practically all the time. But if a prisoner is violent, is that prisoner isolated, or what forms of restraint are used in relation to him? It's not compulsory to take up education, but obviously it would be very beneficial, and I know of lots of people who went into prison and turned their lives around and came out. But are there ways of trying to encourage people to take up the education when in prison? Okay, thank you.
I'll start at the beginning, Deputy. In relation to the data, I mean, I can't do anything other than agree with you. That study was carried out by the National Forensic Mental Health Service. It's more than timely that study would be carried out again. And I suppose what we see on the ground is an increasing acuity in relation to the needs that people are presenting with. So it is absolutely timely that we do that piece of research now. And as I say, we're engaging with the HSE. It's not research the Prison Service would do itself, but it's research that we would do in conjunction with the HSE. So certainly that's an absolute priority for the Prison Service. And I can't do anything other than agree with you, Deputy. It's certainly not before its time. In terms of accessibility, I mean, people have got tools to assist them in relation to their disability, and if they need, particular items, they're provided. And we're doing quite a lot of work with our education service at the moment in terms of technology and how technology can assist people in terms of learning. So I mentioned we've introduced the C-pens, which are the reader pens. We're introducing a form of technology within our prisons, which is a tablet to support people in terms of their learning. We've been slow to come to this, and I think, historically we would have taken a very security-minded approach to things and would have, sort of decided that the security risks meant we couldn't introduce technology within the prisons. But what we know is that introducing technology in the prisons opens up the horizon for so many people in terms of accessing not just educational material, but also material in relation to mental health. So we're working on a new strategy at the moment, and digitisation and the use of technology to assist learning in prison is going to be a key component of that strategy, Deputy. I can absolutely assure you in relation to that. In terms of psychology, we have our own psychology service, and I might just ask Emma just to give you details of the number of staff that we have, and maybe talk to you about the waiting lists, which are quite significant.
Thank you. The Irish Prison Service directly employ the majority of psychologists that are working with us, and in each closed prison there is now a senior psychologist who manages a number of psychologists and assistant psychologists who are an unqualified grade who are starting their training. We recently employed somebody on a part-time basis to work in the open centres as well, and that's a new departure for us and really positive in terms of supporting people with primary care mental health difficulties in the open centres shown Shelton Abbey and Loughlin House. We have 12 senior psychologist posts agreed, 24 psychologists and 14 assistant psychologist posts. Of that, as it currently stands, because of challenges in recruiting psychologists nationally, we have 9 psychologists, 10.4 senior psychologists and 14 assistant psychologists, but have planned a very significant recruitment drive this May and annually from now on in order to really try to boost our psychologist numbers. And we've also, for the first time in 10 years, restarted our sponsoring of training of psychologists as well in conjunction with the HSE. So the HSE sponsor the majority of people who train as psychologists in the various different universities across Ireland. The Irish Prison Service has now joined that, and 2 people are now currently sponsored with UCC, and they will come on board and be contracted to work with us for 3 years after their training, and we plan for another 2 this September coming. In relation to the wait lists, absolutely, that remains an ongoing challenge, particularly in prisons like the Midlands prison. It's a very large prison, and we really, recruiting psychologists to that location has always been a big challenge to us, which is why the 2 new student psychologists are actually contracted to work in the Midlands prison once they qualify. I will have to agree with you in relation to the challenge around wait lists. I mean, generally, the wait list is anything from 6 months to a year to see a psychologist. And considering that many of the population are actually doing sentences of under a year, that becomes a real problem. We end up having to try to refer people out on into the community again.
In terms of the issue the Deputy raised in relation to people finding themselves in contact with the criminal justice system by virtue of having a mental illness and some of the behaviours that might be demonstrated, we have recently published a mental health task force report, and that looks at 3 different areas. It looks at diversion, so where the Gardaí come in contact with somebody whose predominant presenting issue is a mental illness, that there is a diversionary pathway for them to take them to access appropriate services so that they don't have to take them into a custodial setting to ensure their safety and the safety of the public. So there's quite a lot of work and a lot of recommendations around that. There are also recommendations in relation to how we manage people with mental illness, and particularly people with severe and enduring mental illness within our population. So at any one time, the National Forensic Mental Health Service, who provide a really excellent in-reach service to us, have about 250 people that they're managing with severe and enduring mental illness, and we're talking about psychosis, schizophrenia. So we are looking at ways how we can better manage that population within the prison system, and potentially looking at a dedicated unit where people would wait while they're awaiting admission to the CMH, and where they would come back to from the CMH, so that we can keep them in as therapeutic as an environment as we can. But we just need to be clear, prisons are not therapeutic environments, and they're not conducive to treatment for severe and enduring mental illness. And the third part of that task force and the recommendations that have been made are around through care. So it's really important, where somebody's stabilised in a custodial setting, that there is a very clear pathway for them out into accessing services within the community. So there is a group that's been established to oversee the implementation of that report, and I think that's hugely important in terms of changing the landscape of people with severe and enduring mental illness coming in contact with the criminal justice system at all. I might ask my colleague Fergal Black to come in around that issue, and I think you raised an issue around how do we deal with violent and disruptive prisoners, and we can certainly address that question for you.
Yeah, thank you, Karen. Morning, deputies. I'm involved, I kind of oversee a unit we established in 2018 called the National Violence Reduction Unit. It kind of mirrors similar units in the UK, which are called close supervision centres. So in that unit today, we have either 6 or 7 prisoners. I think it's 7. These are people who have a real propensity for violence while in prison, who have demonstrated escalating violence. A number of them have killed while in prison, and we're managing them. But the really important aspect of that is, in setting up that unit, we set it up to develop a relational approach to manage the risks, right? So we have an intensive level of staffing there. It's co-managed by a governor and a senior psychologist. It's a two-pronged approach, a psychologically informed approach. Each officer is assigned one of the prisoners on each side of the roster to engage with as their personal officer. I suppose what I'd say about that is, of the 6 prisoners who've been there for a considerable period of time, 5 of them, when they entered the unit, had been on barrier handling in the prison they came from. That meant our staff, in order to deal with them, were in full riot gear. None of those prisoners have been in barrier handling for 6 months, a year, and actually we'd only 1 prisoner in barrier handling in the last 2 years. So it's the relational approach, to the extent that some of the prisoners, when they're opened up in the morning, will say, I'm not coming out, because they know the way they're feeling, or how that if they come out, they're likely to assault a member of staff, and they don't want to do that. And we consider that a real success. So we're managing people. It's not for people with psychotic, schizophrenic, that kind of severe and enduring mental illness. It's for people where we're trying to address those risk factors associated with that real high propensity for violence, right? As the Director General has said, I'm also chairing a group looking at developing a specific unit for people who are either awaiting admission to the CMH or, more importantly, returning from the new CMH. And we're very fortunate. There's a fabulous facility built in Portrane now, which replaced Dundrum as the new Central Mental Hospital. Yes, they have their challenges like we have in terms of recruiting staff, and we're working through those. But what we want to do is, when somebody goes to the CMH and receives their treatment, they're stabilised, they can compel them to take medication, and they're in a good place. If they still have a propensity for violence, they come back to the National Violence Reduction Unit. If, as most will, they're stable, but coming back to a general population and a landing, they'll probably decompensate, many of them, very quickly. Because, if I'm honest, there can be access to drugs and other intoxicants. So we want to create an environment similar to the NVRU ethos, where people come back, where they're supported in their recovery, where we have intensive staffing, we've our colleagues from the National Forensic Service, we've our nursing, psychology, we've an OT manager coming on board, where we can support those people. Some will then be able to move into general population, and some will probably end up spending the rest of their sentence there because they need that supportive environment. So we're at an advanced stage of discussions with our colleagues in the Forensic Service. We've identified a location, we've a bit of upgrading work to do, but it's a facility that will accommodate about 50 people in custody, and we would see that there would be kind of 17 on 3 floors. 2 of the floors would be people coming back from the CMH, so we start to get more admissions, and we're able to bring them back to an area where, as I say, they can maintain the recovery. And the other one would be for people who are that bit unstable, awaiting admission to the CMH. So that's really, in terms of violence and in terms of people with severe and enduring mental illness. We have the National Violence Reduction Unit open for 3 years now, and we'd hope next year to have the mental health unit in conjunction with the National Forensic Service operating.
And Deputy, just to say, if there's anybody who has a concern about a loved one in our custody, we might not be able to share specific information, but certainly the Governor or the chaplain of that prison would be able to give reassurance to that family in terms of how somebody has been treated. But we never handcuff people in our custody. That's not our ethos. People are treated with care and compassion and empathy at all times by our staff.
A real tragedy is that we regularly get phone calls from family members who have had to take out barring orders against their loved ones, and their loved one then ends up in custody. And they're naturally, they still their child, worried about them. And we as the DG has said, our staff do their best with them, but sometimes they're not in the right environment.
If someone was diagnosed with schizophrenia, for example, do you get that information? Like
the clinicians get the information. So, as Dr. Regan was saying, and Emer as Chief Nurse Officer, in every prison weekly there's a multi-agency meeting, right? And information. If you take Clover Hill, which I would argue is the busiest acute psychiatric unit in the country, right? The National Forensic Service, who have a full team there, our psychology team, our chaplaincy, our governors, our healthcare team, doctors, they would meet every week and discuss each of the patients, so they would share pertinent information between colleagues. Obviously, we have to adopt the same principles in relation to medical confidentiality as would adopt in the community. But I don't know if Emer or Emma want to come in on that.
Just from the nursing point of view, we often have it as part of somebody's warrant where a judge might have identified that they should have a psychiatric assessment, and that would be in the case where there isn't an established diagnosis provided. You know, depending on how well or unwell somebody is, often a family might have given collateral information, and often it might be part of somebody's defence in court that would be presented like a psychiatric report if they have an actual diagnosis. So, pardon me. We would then obviously pursue that within the prison, but there would be people who obviously aren't formally diagnosed in advance of coming in, and that would be either picked up at the committal interview that they're unwell, or again with other services work we would refer them to the forensic InReach psychiatry team, which is a huge support to us and always available. We have both nurses and consultants, registrars and full teams coming in, and along with psychiatry, psychology, nursing, all work together to basically get that diagnosis and find appropriate treatment plans and work placements for that person. And I know, Deputy Ellis, you were actually asking about what happens if people don't engage and go to work or education. It's very much taken into account. If somebody has an established disability or challenge, you know, nursing would communicate with the work and training officers and the operational staff on the landings to basically say, you know, he mightn't be good to go to work today, or he might be a little bit slow in the morning. And the very experienced prison officers, you know to give somebody a little bit more time. Maybe somebody needs a little bit of a jolly along, a little bit of encouragement, but that's all very much taken into account, and there's nobody penalised. There's an incentivised regime where people are rewarded and encouraged. You were talking about education. Do they, you know, are they encouraged to go to education? They're encouraged to be active throughout the day, engaging in work or training or education, but nobody's ever penalised if they have a disability. And we've often had to kind of say, you know, this person needs a little bit of a break from going to workshops today. While it might be good for them to be engaged, it's not, you know, they're just not able at that time. So we would always intervene. And again, the multidisciplinary team approach from the prison officers, psychology, nursing, psychiatry, everybody working in the one direction with the prison governors to try and make an appropriate plan that, you know, is flexible. People, you know, the plan changes as people move through their sentence and might be more well or settled.